My name is Dr. Sema Hart. The following is an instructional video intended for medical students and first-year residents on how to complete a normal newborn physical exam.
The stethoscope should be cleaned with alcohol prior to auscultation, and it can be warmed by placing it in the palm of the hand. I begin my newborn physical exam with the heart exam. Before I stimulate the baby, the heart rate is generally lower, and it is easier to hear all the components of the heart sounds. Before actually touching the baby, your observation is an essential part of your physical exam. Observe chest symmetry, respiratory effort, and color of the baby. The newborn baby has an irregular respiratory movement. This is due to an immature neuromuscular system. Timing the respiratory rate of a newborn should be taken for a full minute. If the rate is counted for a 15-second duration and multiplied by 4, the calculated respiratory rate could be in error. During the heart exam, the point of maximal impulse should be noted and is normally at the left lower sternal border, which is much different than a child or an adult. I auscultate the PMI during my exam. Try to think of some pathologic reasons why the PMI would be shifted in a newborn. The lung exam should be performed while the infant is still quiet. Be sure to appreciate the symmetry of the breath sounds. Also note that a breath sound could be mistaken for a murmur. Obviously, the rates will be different. Then the baby may be examined from head to toe. It is important to remember that much of your physical exam is observation of the baby and listening to the baby. Much of your neurologic exam is actually based on watching the symmetry of movement of the extremities, watching the faces during crying or sucking, and listening to the character of the cry. Is it high-pitched, weak, hoarse? Palpate the anterior and the posterior fontanelles. The anterior fontanelle is diamond-shaped and should be open at birth. Palpate the head for evidence of molding. Molding is the overlapping of the skull bones which has occurred to aid the infant in the exit through the birth canal. This is the approximate location of the anterior fontanelle. The posterior fontanelle is found here along a sagittal line from the anterior fontanelle. The posterior fontanelle should be closed or fingertip at birth. A large posterior fontanelle may be a sign of hypothyroidism. This is a diagram of the anterior and posterior fontanelles from above the baby's head. The top of the screen is the front of the head. The anterior fontanelle is bordered by 4 skull bones. The edges of these 4 bones produce a diamond-shaped area. The posterior fontanelle is bordered by 3 skull bones, which produce a triangle-shaped area. The following is to illustrate the difference between a caput sexadenum and a cephalohematoma. Illustrated is a coronal cut through the cranium, and this represents the frontal skull bones, for example. A caput sexadenum is a collection of fluid within the scalp, which is primarily edema and possibly a small amount of blood. A cephalohematoma, in contrast, is a collection of fluid which is subperiosteal. It is primarily blood with possibly a small amount of edema. Both types of swellings may occur secondary to the delivery process or if the delivery was assisted by vacuum or forceps. A cephalohematoma takes longer to resolve and may be responsible for the development of hyperbilirubinemia. A cephalohematoma is also defined by which bone it involves and does not cross the suture line. Examine the faces for any syndromic or chromosomal characteristics. The eye placement, the ear placement, movement of the facial muscles during crying, patency of the nose and mouth should all be observed. Also, the mandible should be symmetric. The red reflex is best examined at the end of the physical exam. An imaginary line is drawn through the palpebral fissure to check ear placement. If the entire ear is below this imaginary line, then the baby has a low-set ear.